Let's stick to the lenvatinib scenario. And Peter, first-line lenvatinib, let's assume based on the best we can get here, and it's not necessarily the only answer, but pembro as second line.
Okay.
What will be your third line?
Well, I mean, the plot thickens and the evidence thins here. So I believe that the only evidence we have in any shape or form for patients receiving quote-unquote third-line therapy comes from the Celestial trial of cabozantinib, where the fairly generous inclusion-exclusion criteria allowed patients to for sure be on sorafenib, but also have received a second line of systemic therapy. I believe about 20% of patients actually fit that scenario, and about, I believe, 8%, something like that, may have received some component of IO therapy. We obviously have very small numbers to gauge whether in that small subset of patients there was benefit, but at least in the overall cohort of patients who received second-line therapy, there was still some benefit. And therefore, one might surmise that in that particular setting, cabozantinib would be a reasonable option for those patients, assuming they continue to have adequate liver function and functional status that would allow them to pursue therapy, which I think is our collective responsibility and task, is to keep these patients in decent shape from a functional and liver perspective to allow them to pursue potentially more life-extending therapies.
So Catherine, I like what Peter is saying, and tell us a little bit more about cabozantinib, because clearly it is second line, solid, but also suggestive of third line data as well within the same study. Is it easy to give, like tolerated?
It's relatively easy to give. It's one dose a day, so once a day. The full dose is 60 milligrams, and you dose reduce to 40 and then 20. If you have someone with, say, Child's B, it hasn't really been studied in Child's B cirrhosis, but we do have dosing that those patients would start at 40 milligrams. So you really can adjust the dose as you need to. It has the TKI side effects that you expect, diarrhea, hand-foot skin reaction, hypertension, poor appetite, some weight loss. But really, with all of these side effects, they're manageable, and I'm really pretty aggressive with my patients in terms of seeing them back quickly and adjusting the dose, treating their side effects, keeping their side effects under control to be able to keep them on therapy so that they can have that clinical benefit.
Fair enough. So there's a lot of information that we learned from all of our colleagues here. Number one, I would like to start with what Dr. Fournette started the discussion with, is that there was a default that the sorafenib was the only available drug at that time, and that's why all those studies were kind of one way or the other compared and considered after prior exposure to sorafenib. Number two is, I like very much also what Catherine ended up with, which is we want to make sure that the patients are monitored very carefully and very closely, because these TKIs can have a certain complexity to them, let alone the IOs, and we want to make sure that they keep patients under our kind of close observation at all times. In regard to the choices, we heard them a little bit one way or the other, and it's not like I have any better answer than what our dear colleagues have mentioned, but if anything, the choices at the moment are regorafenib, but as we heard from Dr. Koueri and Dr. Ghulam, has a very robust requirement of prior exposure to sorafenib, tolerance of sorafenib, and progression on sorafenib, so patients get regorafenib. And this is already within the FDA approval, is that prior sorafenib will be required per se. Number two is cabozantinib, rather very robust data, and if anything, as we heard also, it can apply not only for second line, where really it's a primary endpoint of the study, and by all means is priority, and add to it a third line opportunity or potential is there. We heard from Dr. Fournette is that the tolerance of the drug is rather acceptable. I have to admit, I have a lot of experience with cabozantinib, and if anything, we have seen that the drug is acceptably well tolerated. It might require certain dose adjustments because of the fatigue component, and as we heard, 60 milligram to 40-20. The data that we published in the New England really supported very much the applicability of the drug to patients that are equal to all of us whom we see in clinic. The third option that we heard about on the tangent, but very important as well, is ramucirumab, which is an anti-VEGF, a great tolerance, but there was a requirement in that study, which is the REACH2 study, to make sure that patients had an alpha-fetoprotein more than 400 to get the drug. This kind of remain a little bit of debate. What's the value of the alpha-fetoprotein? But by all means, we have seen incredible data, especially when the prior REACH study, which allowed all patients to get on, and then they looked specifically at the patients with the high alpha-fetoprotein. When they joined this with the high alpha-fetoprotein patient from the REACH2 study, the outcome definitely was more apparent, and by all means, it's an option per se. And then Dr. Al-Kuwari invited us to really look into the checkpoint inhibitors in regard to second-line therapy. And I would say that disappointingly, but it is what it is, the data in first line of nivolumab versus sorafenib is negative. And I like very much how our colleague discussant at ESMO, Dr. Vogel, said it. He said it 3 times. It's a negative study. In addition to that, in regard to the pembro versus placebo in second line, again, as much as we like to really see the quote-unquote clinical benefit, as Dr. Kuwari referred to, statistically it was negative, so it's a negative study. Nonetheless, to give credit, those 2 drugs are available and already approved in second-line setting in HCC. Why is that? Actually, the FDA probably was mostly keen on the duration of response. In other words, patients can stay on the therapy for a long, long time, and that's why we like them very much. And as such, there is nothing but appropriate and correct in giving pembrolizumab as an option in second-line setting. And of course, nivolumab could be another option in second-line setting. With this said, however, as you noticed, I kind of played this scenario with the patients with prior exposure to lenvatinib specific. Why I chose lenvatinib? Because number one, of course, we are well aware of the conditional thing between sorafenib and rigo, and I don't want all the answers to come rigo straightforward. I want to make sure we build a little bit more complexity to the story. And number two, to be fair, lenvatinib has its presence in the market because of the appropriate tolerance and the great management, and of course, the excellent progression-free survival, as we heard from Dr. Ghulam, the 3 times increase in PFS compared to sorafenib, despite it was an inferiority study, and an impressive response rate by imaging, close to 24% by RECIST 1.1 and close to 41% by modified RECIST. What we heard actually from Peter a second ago is that cabozantinib has quote-unquote second and third line applicability, i.e. if patient get atezolizumab, and let's say we're going to go through the scenario of we'll go to second line automatically and we do cabo, but let's say no, we would like to revisit the first line approaches as also was suggested by Anthony, and we'll go to sorafenib or lenvatinib. I think, do you agree that it's kind of nice that we have third line data on cabozantinib anyway?
It is nice to have that third line data on Cabo. I don't know that that would make me want to save it back for third line, because really clinically very few patients are going to make it to third line. Usually by the time you're progressing through first line, half of them can't get second line because of progression of their liver disease or poor performance status. So it's really a very small percentage that will make it to third line, I think. And I don't want to lose the opportunity to give them a very good TKI in cabozantinib if that is where I think the patient would be most appropriately treated.
Well, that's quite fascinating. So we are hearing different opinions on that. And to be fair, it's not like we are, any of us, but working on very thin ice in regard to the choices of therapy. But nonetheless, the schools of thoughts are, ironically, all of them are turning around ultimately around cabozantinib, because this is the only one that really had a second and third line therapy, i.e. if we think of the approach is that, as Catherine just mentioned, that we want to make sure that get every opportunity for the patient on the best available data, and as such, rather than go backward, move forward, and as such, atezolizumab followed by cabozantinib. On the other hand, as we also heard from Peter, is that maybe after all, we are keen on giving every opportunity, because I probably can understand Peter's view is that after all, the data that we spent tons of time and a lot of patients contributed to, it's not a waste in regard to sorafenib, lenvatinib, etc. And as such, the idea of going with atezolizumab back to, for example, lenvatinib, and then moving forward after that to cabozantinib based on the third line data is also valuable. What will kind of decipher that ultimately? I think it will be kind of, time, further data availability, and of course, the real-world experience, which is going to be very important. I think the new advent that we have, it used to be called in the old days the phase 4 studies, but I think now we have certain entities that can help us in regard to real-world evidence and real-world data. That's going to be probably guiding a lot of our decision-making in regard to those treatment. Again, this is yet to be discovered.